Hi Kansha, how are you? I hope I'm audible. Okay, so we'll wait for a few minutes so that everyone could join and then we would begin. So, all of you who are new here, so myself, Dr. Simran Kaur, I'm a radiology resident and I'm an ECFMG certified physician. So, I've passed my USMLE step 1 and step 2 and I got ECFMG certified, and right now I'm doing the radiology residency. Okay, now let us begin this high yield series, which is very, very important. So, I've picked up the topics from the past few years of INICET and NEET PG, and we would be covering those in an interesting way, not like in the conventional way. Okay, we won't be discussing per se the total exact questions. So, we would be more focusing on doing and mastering the topics that were being asked. All right. Okay, so someone is asking for the PDF for the previous class. So I've uploaded that on my Telegram group. That is by my name. I'll send the link for my Telegram group also. And along with that, I'll ask someone from Unacademy to post the PDF here also. All right, so let us begin the class. So number one high yield topic for today. That is the oxygen hemoglobin dissociation curve. Now this is a very high yield topic for any exam. Okay, be it for university exams, INSAT, NEET PG, USMLE. So these are very important topics. Number one, when you talk about this oxygen hemoglobin dissociation curve, what what are the main things that you have to remember? So we won't be wasting time at all. So we would be only focusing on what's important. Okay. So this in red is the normal curve that you get. But if there is shift to the left or there is shift to the right, okay, what are those situations, guys, in which there is shift to the left and there is shift to the right? This is very, very high yield. So you can make a flashcard for this. Okay, so the conditions in which there is left shift and the conditions in which there is right shift. So number one thing that you should be very familiar with is that whenever this left shift is taking place, so this is the left shift that I'm highlighting. Okay, that indicates the increased oxygen affinity. So whenever there is left shift, that indicates the increased oxygen affinity, okay, of the hemoglobin. Remember, whenever there is right shift, the one that I'm highlighting with pink, and I've labeled it as B, it indicates that there is decreased affinity for oxygen, okay? So this indicates that there is decreased affinity for oxygen. So keep this point in mind. Moving on to the main point. What are the conditions in which you see the left shift of the oxygen hemoglobin dissociation curve? Okay, so number one is decrease in the PCO2. Then number two is decrease in the body temperature. Number three is decrease in the H positive. Okay, so when the H plus is reduced, obviously that is the acidic component. Acidic component is reduced, so what will happen to pH? pH is going to increase here. All right, and third, the last point, that decrease in the 2,3-BPG, that is 2,3-bisphosphoglyceric acid. So what you have to remember is, if you can see the direction of the arrows here, all of them are in the decreasing way. Okay, so all the arrows are in this way. So that means PCO2 decrease, body temperature decrease, 2,3-BPG decrease, and H positive decrease. All of these will lead to what type of shift of the oxygen hemoglobin dissociation curve? Your answer is going to be the left shift, okay? And hence more affinity for oxygen. When you talk about the right shift of the oxygen hemoglobin dissociation curve, the arrows are going upwards. Okay, so guys, remember this. Downwards going arrows for the left shift, upward going arrows for the right shift. Okay, so increase in the PCO2, increase in the body temperature, then increase in the H positive and increase in the 2,3-BPG. So this is a very, very high yield topic. I've only written the things that are important for us, so make sure you know this flashcard. All right, moving on to the next topic. Before that, I want to ask you one question here. Hemoglobin. Where is hemoglobin present? Where is hemoglobin present? Yes, anyone? Where is hemoglobin present? Yes, I'll upload the previous class PDFs, okay? You can watch those on my Telegram group. Yes, so the hemoglobin is there in the RBC. What is the function of hemoglobin? What is the function of hemoglobin? Your answer is that it would carry the oxygen and it would deliver it to the tissues. So transport and delivery. Transport and delivery of oxygen. Okay, this is the basic thing. Now, hemoglobin contains iron. Can anyone tell me what type of iron is contained in hemoglobin? What type of iron is contained in the hemoglobin? I'm typing the name of my Telegram group if you are asking. Yes. Just a second. Okay. The hemoglobin that contains the iron in its reduced form, that is ferrous. This is oxyhemoglobin. Okay. Now, guys, you tell me a situation in which the hemoglobin contains the oxidized form of iron, that is ferric iron. What is that? Yes. What is that known as? Anyone? Exactly. Sai, you gave the right answer. The answer to this question is methemoglobin. Methemoglobin. Okay, so guys, remember, normally the hemoglobin contains the iron in the ferrous form, that is the reduced form. If hemoglobin is containing the iron in the ferric form or the oxidized form, it is known as the methemoglobin. All right, remember this point. Moving on to the next high yield topic. Okay, now what I've written here is due to chronic GERD. Now, what is this GERD that we are talking about here? So let us talk about it. What do you understand by GERD? Anyone? Yes, GERD stands for gastroesophageal reflux disease. Gastroesophageal reflux disease. Okay, so let us try to understand this quickly. This is the esophagus. And this part here is the lower esophageal sphincter. Okay, this is lower esophageal sphincter. And this is stomach. Now, guys, if someone is eating something, the food particles will move into the stomach via the esophagus. But if the tone of this lower esophageal sphincter is not proper, if the lower esophageal sphincter is not having proper tone, okay, it is in the relaxed state, what will happen? What will happen? The food particles will be going upwards. They will be going backwards into the esophagus. There will be reflux. Okay, this is what is happening in the gastroesophageal reflux disease. All right. Now, if someone is suffering from chronic GERD, first of all, the GERD patients, they usually have the heartburn. Okay, they have uneasiness and they have problems in eating, and they would feel the reflux. Okay. Now, if someone is having chronic GERD, so this is a very important point. What problem could arise in the patients who have chronic GERD? Anyone? What problem could arise in a patient having chronic GERD? Yes. Let me see who can answer this. The answer to this question is there would be a kind of metaplasia. Okay? Metaplasia. See, first of all, you tell me what is metaplasia. Metaplasia means the conversion of one type of mature or replacement of one type of mature epithelium into the another type. Okay? So there occurs a type of metaplasia here if chronic GERD is there. Okay, what is the reason? The reason is, supposing this is stomach. Stomach contains acid, that is HCl. Okay, a quick question from GIT. From where is the stomach acid coming? Who produces the HCl? Anyone? HCl is produced by gastric parietal cells. Okay, your answer is gastric parietal cells. Okay, second question is, apart from producing the HCl, what else is being produced by the gastric parietal cells? So what you can do is, you can make a flashcard here. Okay, write down the gastric parietal cells and mark 2 arrows under it. So number one thing that is being produced by the gastric parietal cells is the HCl. And the second thing that is being produced by the gastric parietal cells is intrinsic factor. Excellent, Ravi Kiran. Intrinsic factor. Okay. Now, can anyone tell me the function of intrinsic factor? What is the function of intrinsic factor? Yes. Intrinsic factor is playing a very crucial role in the absorption of, very important role in the absorption of vitamin B12. Excellent. Very important role in the absorption of vitamin B12. Okay, know this point. Now coming back, stomach contains the acid. Now we are talking about the reflux. Okay, so the acid along with the food particles would go up in the esophagus, but normally esophagus is not used to of getting the acid. Okay, the esophagus is not prepared to tolerate the acid, but if this happens continuously, nature has provided a way in which esophagus would try to become strong. Okay, it will try to tolerate the acid that is coming along with the food particles in chronic GERD. So what happens? There occurs a type of metaplasia. So this is a very important point. Okay, there occurs a type of metaplasia in the esophagus. What is that known as, the condition? What will you answer here? This is known as Barrett esophagus. Very, very high yield Barrett esophagus. Okay, this is very high yield point. Now, a second high yield point regarding this is, okay, what type of epithelium is converted into what type? So this is also very, very high yield. Stratified squamous, non-keratinized stratified squamous epithelium is getting replaced by the columnar epithelium, and there will be presence of goblet cells also. Okay, so you should always know, okay, what changes take place in Barrett esophagus. Your answer is going to be the conversion of stratified squamous epithelium into the columnar epithelium, and along with the presence of the goblet cells. All right. Yes. Now moving on to the next point. So I've seen questions where they had asked this point regarding Barrett esophagus. Now, why are we concerned about Barrett esophagus? What is the problem? What is the problem with Barrett esophagus? Yes. So it is written in front of you. Barrett esophagus increases the risk of dash. Okay, so what will you fill here? Your answer is going to be the esophageal adenocarcinoma. Okay, so what you're going to fill here is esophageal adenocarcinoma. Esophageal adenocarcinoma. Okay, so that means Barrett esophagus is a pre-malignant condition. This is a pre-malignant condition. All right. Moving on to the next point. Now, since we are talking about the esophageal adenocarcinoma, okay, You also should know the two varieties. So this was also being asked in one of the INICTs, okay? That esophageal carcinoma. Esophageal carcinoma is of two types. We have a squamous variety, and then we have a adeno variety, that is adenocarcinoma from the glandular epithelium. Whenever you read this term adenocarcinoma, na guys, you have to know one thing. Adeno is related to glands. So adenocarcinoma is a carcinoma arising from the glandular epithelium. From the glandular epithelium. Okay. So the esophageal carcinoma is of two main varieties, squamous cell carcinoma and the adenocarcinoma. Now, what you have to remember about these? First of all, the location. So the squamous cell carcinoma of the esophagus would involve mostly which location of the esophagus? Your answer is going to be upper two-third. So imagine in the question it is mentioned that the patient had chronic GERD and ultimately the patient developed the esophageal carcinoma. Okay. Now, it was found that it was squamous cell carcinoma, the squamous variety. So, where would it involve? It would involve the upper two-third of the esophagus. Okay. Similarly, when you talk about the adenocarcinoma, the adenocarcinoma of the esophagus would affect the lower one-third. Okay, lower one-third. So, you should know the differences. How would you get to know which variety of esophageal carcinoma it is? Okay, so based on the few points we would be talking about here. What are the risk factors for squamous cell carcinoma of the esophagus? So this is also very, very important point. Alcohol. So if someone is consuming alcohol from a long time, this increases the risk of squamous cell carcinoma of the esophagus. Similarly, if someone is consuming hot liquids, okay, all the liquids and the patient is consuming them very hot, okay, so what happens is the risk of squamous cell carcinoma of the esophagus increases. Then achalasia. Achalasia. So can anyone answer this question? What is achalasia? What is achalasia? Anyone? What happens in achalasia? Yes, guys. What happens in achalasia? Okay. The lower esophageal sphincter fails to relax. Okay, in GERD, what was happening? The lower esophageal sphincter tone was reduced. In achalasia, the lower esophageal sphincter's tone is very high. That means it is not going to relax. So what is the consequence? What is the consequence? The patient will have problem in swallowing. The food particles won't be able to properly go into the stomach. So what will happen? There will be dilatation here. Dilatation of the lower esophagus. Okay. Another point here. The patient will have dysphagia, that is difficulty in swallowing. Okay. So achalasia is a risk factor for the squamous cell carcinoma of the esophagus. Remember this important point. Then talking about the risk factors for the adenocarcinoma. So chronic GERD, number one. This is a risk factor for the adenocarcinoma of the esophagus. And chronic GERD in itself is a risk factor for Barrett esophagus. Barrett esophagus is also a risk factor for adenocarcinoma of the esophagus. Then tobacco, the consumption of tobacco, and obesity. So if a patient is obese, the risk of adenocarcinoma of the esophagus is increased. All right. Moving on to the next high yield topic. So you might have seen this picture in the past few years. They have asked about it. Okay. So this is a CT scan picture, and then this is a endoscopic picture. So looking at these pictures, can you tell me what condition is it? So I'll minimize it so that you can view both the conditions together, both the pictures together. Yes. So what is this? Anyone? Let me see who can answer this question. So this was asked in the previous years. Please know this. What is this condition? Please diagnose it. Okay, Akanksha says look cerebriform. All right. What is the name of the condition? Exactly. The name of the condition is Menetrier's disease. Okay. This is a very high yield image. Please know this. So this is Menetrier's disease. Now what happens in Menetrier's disease? If you can see the gastric rugae, they are, how are they appearing? So what you have to remember is there is hyperplasia, the hypertrophy of the gastric rugae, okay, and the gastric mucosal hyperplasia takes place. So these are the two keywords that you have to remember regarding the Menetrier disease: the gastric mucosal hyperplasia and the hypertrophy of the gastric rugae. Now, what second point that you have to remember here? Look at this endoscopic picture. What is it resembling? Yes, this appearance resembles what? The answer to this question is going to be the gyri in the brain. So look at this picture. Okay. So this picture shows you the gyri. So this is giving the similar appearance that we saw in the endoscopic picture of Menetrier disease. Remember, the gastric rugae that are hypertrophied, they will resemble the gyri of the brain. Okay. Remember this point. And why is it important? It is important because this is a pre-malignant condition. This could lead to gastric carcinoma. Okay. This is important because this is a pre-malignant condition. So remember this picture, I'll show you again. The gastric rugae, they are hypertrophied. The gastric mucosal hyperplasia takes place. Okay. So this is Menetrier's disease. Moving on to the next high topic. So if any question says that the patient is having fever, okay, supposing they say that patient is having, the body temperature is 102 degree, okay, along with that, when the physician auscultates, there is new onset murmur. There is new onset murmur. So fever plus new onset murmur, this is a very, very important hint for infective endocarditis. Okay. So what you have to remember? So let us do some integration from the microbiology here. Okay, regarding the infective endocarditis. So what you have to remember is, supposing they give you few hints, you have to identify that which organism could be involved or implicated in causing the infective endocarditis in that particular situation. Okay. So what are the hints for infective endocarditis? Let us try to understand those. So number one, if they say that the patient is having colon cancer, or they say that the patient is having ulcerative colitis, so here ulcerative colitis is also the possibility that could be given. Ulcerative colitis, okay, plus infective endocarditis. So if in the question it is mentioned that the patient is having colon cancer and the patient is having infective endocarditis, that means which organism could be implicated in causing this infective endocarditis? Your answer is going to be Strep bovis or Giloleucus. Okay, so this is going to be your answer. So this is the integration from microbiology. So the organism implicated here is Streptococcus bovis or Giloleucus. Okay, moving on to the next hint. So supposing the question mentions genitourinary instrumentation or manipulation, okay, or they mention the patient having UTI plus infective endocarditis. So the combination of UTI plus infective endocarditis, guys, which organism could be leading to this? Anyone? Which organism could be leading to this? Your answer is Enterococcus. Okay, so this is the enterococcal infection. Remember this point, enterococcal infection. So genitourinary instrumentation or manipulation or UTI plus infective endocarditis. If these hints are mentioned in the question, the organism is Enterococcus. Okay. Which drug would you prefer for Enterococcus? Which drug would you prefer for Enterococcus? Yes. You would prefer vancomycin. Okay, vancomycin. Vancomycin. But if the patient is resistant to vancomycin, vancomycin resistant enterococcal infection, which drug could you prefer here? Linezolid. Linezolid. Okay. Next question from pharma. Vancomycin is effective against which type of organisms? Gram positive or gram negative? Gram positive or gram negative? What would you answer here? Vancomycin is effective against gram. Yes, guys. Gram positive. Excellent. Tabrez, you give the right answer. Gram positive. Okay. Another question. Vancomycin is usually given via parenteral route. Vancomycin is usually given via parenteral route. Name a very rare indication where oral vancomycin is given. So very rarely oral vancomycin is given. What is that situation? What is that infection in which you give oral vancomycin? Anyone? What is the situation in which you give the oral vancomycin? Exactly, Harita, you gave the right answer. The answer to this question is Clostridium difficile infection. If you're not given this in the options, you could also be given pseudomembranous colitis. Pseudomembranous colitis. Your homework today is to read and learn the drugs that could lead to pseudomembranous colitis. Okay, this is very high yield. So please know the drugs that lead to pseudomembranous colitis. Now, one point here. Supposing they give you a history in which the patient had been hospitalized due to some kind of infection. The patient was on IV antibiotics. Now the patient develops diarrhea. And the TLC count is raised. Okay, so this is a typical history for what type of condition? So what type of condition we are talking about here? Your answer is, this is pseudomembranous colitis or Clostridium difficile infection. Okay, so this is a typical kind of history that could be mentioned in the question if they have to point towards pseudomembranous colitis or Clostridium difficile infection. Clostridium difficile infection. Okay. Coming back, let us talk about another hint. Supposing in the question they have given you, the patient underwent a dental procedure, okay, or there was some the biopsy of a respiratory tract. Along with that, now the patient developed infective endocarditis. Okay, so which organism could be responsible in causing infective endocarditis in this situation? So remember, if the question mentions dental procedure or if the question mentions biopsy of the respiratory tract and the patient developing the infective endocarditis, your answer to this question is going to be, yes, viridans group of Streptococcus. So Strept viridans. Yes, you are exactly right. Mutant mitis. Okay. So Strept viridans, that is very, very important here. Keep this point in mind. Moving on to the next type of hint in infective endocarditis. So supposing you are being given an IV drug user. So what they can give is a very thin patient having multiple needle marks on the arm. Okay. So multiple needle marks on the arm and a very thin patient, usually male. Okay. So this type of history would indicate that the patient is IV drug user. Along with that, if they have mentioned infective endocarditis. So infective endocarditis in an IV drug user most commonly occurs due to which organism? Yes. Due to which organism? Your answer is Staph aureus. Exactly. So Dipjyoti, Tabrez, you gave the right answer. That is Staph aureus, Staphylococcal aureus. Okay, so this is very, very important point. Similarly, if I give you another hint, if the question mentions prosthetic valve, if the question mentions prosthetic valve plus infective endocarditis, infective endocarditis. So, what do you think? Which organism? Yes, there are two possibilities. Okay, there are two possibilities. Staph aureus or Staph epidermidis. Staph epidermidis. Okay, so remember, infective endocarditis caused in a patient having prosthetic valve. The organisms could be the Staph aureus or it could be Staph epidermidis. Moving on to the next high yield topic. Okay, supposing guys, you are being given a situation in which they write that there is an intellectually disabled child and the serum uric acid levels are high and the child is biting his own nails and lips. So what do you think it is? Which condition here we are talking about? Anyone? Okay, so I'll be speaking loudly now. I hope I am audible. Okay, so the condition that we are talking about here is Lesch-Nyhan syndrome. Okay, so look at the hints given in the question. Intellectually disabled child, serum uric acid levels high, the child is trying to bite his own nails or fingers or lips. Okay, so what is this we are talking about? Lesch-Nyhan syndrome. This is very, very important. So INICT is also this is a favorite. Lesch-Nyhan. The spellings may be wrong. Lesch-Nyhan syndrome. Okay. What is this trying to bite his own nails and lips? What are we talking about here? We are talking about the self-mutilating behavior. So this could also be given as a hint in the question. Okay. The children who have Lesch-Nyhan syndrome, they have self-mutilating behavior. That means they try to injure themselves, they try to bite their fingers, nails, lips. Okay, so this kind of behavior would be seen in children having Lesch-Nyhan syndrome. Second question, which is very, very high yield, which enzyme deficiency is associated with Lesch-Nyhan syndrome? So which enzyme deficiency is associated with Lesch-Nyhan syndrome? Your answer to this question is going to be yes, exactly, HGPRT. Okay, the answer to this question is HGPRT. So what is this HGPRT? Let us try to know this. HGPRT stands for hypoxanthine guanine phosphoribosyl transferase. This enzyme is deficient in Lesch-Nyhan syndrome and this is very, very high yield guys. So learn the name of this enzyme. Secondly, what you have to remember, since the levels of uric acid, they are deranged. The levels of uric acid are increased in case of Lesch-Nyhan syndrome. there is increased risk of gout. Okay. Now we have to be very clear regarding the concept of gout. What is gout? Gout is deposition of dash in the joints. So how would you answer this? The deposition of dash in the joints. Whose deposition takes place in gout? Your answer to this question is going to be, yes, monosodium urate crystals. Monosodium urate crystals. Okay, so remember this. The precipitation of monosodium urate crystals in the gout, in the joints. Okay, this is what is happening in gout. And this occurs due to the fluctuating levels. Okay, so guys, remember, gout is not just due to increased levels of uric acid. There is difference. Increased levels of serum uric acid is known as hyperuricemia. This is known as hyperuricemia. Okay, but hyperuricemia is not gout. So don't get confused here. Gout is different. Gout is due to the fluctuations in the levels of uric acid. So fluctuating uric acid levels, they could precipitate gout, and gout means the precipitation of monosodium urate crystals in the joints. Okay. Now coming on to very, very important points. Since we are talking about the crystals, okay, so you should know the characteristics of the crystals in case of gout. Okay, what are the features of crystals that are seen in case of gout? So number one, the crystals of gout, they are needle shape. Okay, so if they try to ask you the shape of the the shape of the crystals in case of gout, your answer is going to be needle shaped. Okay. Second thing, how would they appear under polarized light? Your answer is going to be they are negatively birefringent. So this is very important. Negatively birefringent. Third thing, if parallel light is thrown, what type of color would they be showing? Your answer is going to be yellow. So how you have to remember is parallel is having double L. Parallel is having double L and yellow is also having double L. Okay, so parallel light is equal to yellow color. And under perpendicular light, they are going to be blue. Perpendicular light, they are going to be blue. Okay, these characteristics are very, very important because these are the hints that they could use in the question. Okay, so you have to catch these hints regarding the crystals and then you will answer that this is gout. Okay, moving on to next entity. So guys, there's a situation that is like kind of opposite to gout. Like the crystal seen in that condition, they would be showing opposite property as seen in gout. What is that condition? That condition is known as pseudogout. Pseudogout. Okay. So this is very, very important. Pseudogout. Pseudogout. First question. What type of crystal deposition takes place in the joint space in case of pseudogout? Yes, very high yield. What crystal deposition? Your answer is going to be calcium pyrophosphate. Okay. So write down deposition of calcium pyrophosphate in the joint space. It takes place in case of pseudogout. Second point regarding the pseudogout. There are three conditions that you have to remember that could be associated with pseudogout. What are those conditions? Number one, that is going to be if there is any previous trauma to the joint. Number two is hemochromatosis, in which there is iron overload. Number three is hyperparathyroidism. Learn these three conditions regarding pseudogout. These are the risk factors for the development of pseudogout. Number one, any history of previous trauma to the joint. Number two, hemochromatosis. Number three is hyperparathyroidism. Okay. Next, I'm going to show you a very, very important picture that you will appreciate. It was being asked in the previous years. Okay. So look at this picture. Can anyone answer the question? What is it showing? What are the arrows pointing towards? in this picture? What are the arrows pointing towards? Anyone? What are these arrows pointing towards? What is this X-ray showing? Yes? You might have seen this picture in the previous year's questions. This picture shows chondrocalcinosis. Okay, so this picture is showing chondrocalcinosis. What is chondrocalcinosis? So chondro, guys, whenever you come across the term chondro is related to cartilage. Whenever you come across the term chondro is related to cartilage. Okay, because what are the cartilage forming cells known as? Chondrocytes. Okay, but when you talk about the term chondrocalcinosis, okay, chondrocalcinosis means the calcification of the cartilage. Okay, as the name itself is suggesting, calcification of the cartilage. Here we are talking about which type of cartilage? Articular cartilage. If you can see the radio opacity here, okay, so there occurs the calcification of the articular cartilage. Okay, calcification of the articular cartilage. This is a very important picture. And this is known as chondrocalcinosis, and chondrocalcinosis could be seen in a patient having pseudogout. Okay, pseudogout. So they could show you this picture and then they could give you the characteristics of the crystals and ultimately ask you what is it. In one of the options they could give you gout, and in the other option they could give you pseudogout. Okay, so know this. Now, moving on to the next point. What are the characteristics of the crystals of pseudogout? So what are the characteristics of the crystals of pseudogout? Just like we talked about the crystals of gout, similarly you should also know about the crystals of pseudogout. So the crystals of pseudogout, number one, they are rhomboid shaped. Okay, the crystals of gout were needle shaped. Now here the crystals of pseudogout are rhomboid shaped. So highlight this point. Second thing, the crystals of gout were negatively birefringent. Here, the crystals of pseudogout, that is calcium pyrophosphate, they are positively birefringent under the polarized light. Third difference, under the parallel light, the crystals of gout were yellow in color, and under the perpendicular, they were blue. But what is happening? Opposite here. Parallel light, blue, and perpendicular yellow. Okay. So these are the differences between gout and pseudogout that should be very clear to you. Okay. Now, when you talk about increased serum uric acid levels, guys, you will come across this topic, this syndrome as one of the cause of hyperuricemia. Okay, when you read about the hyperuricemia, you will come across this tumor lysis syndrome. So can anyone tell what is this tumor lysis syndrome? What is this tumor lysis syndrome? Anyone? So let us break this word. Okay, tumor lysis syndrome. Tumor lysis syndrome means the tumor cells, they are getting broken down. Okay, the tumor cells are getting broken down. So let us try to understand the history that could be given to you. So a patient of AML or ALL, or they could tell you leukemia patient. A leukemia patient started on chemotherapy. Okay, a leukemia patient started on chemotherapy. What will happen? So if you start a chemotherapeutic agent, obviously that is going to target the rapidly dividing cells. So the cancer cells, supposing these are the cancer cells, they are going to get broken down. Okay, they are going to get broken down, And what you have to remember is mark 3 arrows under it. When the cancer cells are getting broken down, three main things are getting released from the cancer cells. Okay, what are those things? Number one, potassium. So potassium leaks out from the cells as the tumor cells are breaking down. So potassium, if it is coming out, what will happen to serum potassium levels? Serum potassium levels, your answer is going to be high. Okay, so this will lead to hyperkalemia. This will lead to hyperkalemia. So guys, whenever you talk about the serum potassium level, you should know the normal value, okay? Because any derangement in the serum potassium is an emergency. That is why you should know the normal values. So normal serum potassium levels, they are 3.5, exactly Akanksha, 3.5 to 5 milliequivalent per liter. So know this normal value. This is very, very important. Okay, any derangement in it, be it the more than 5 serum potassium, less than 3.5, these are the emergencies. Hyperkalemia or hypokalemia, dangerous. Okay. Now, second thing, potassium is having effect on the resting membrane potential. Okay. Now, if there occurs hyperkalemia, why are we worried about? Why are we worried here? What is the reason? The reason is that hyperkalemia could lead to, it could induce arrhythmias. It could induce arrhythmias. Okay. Second point. The second substance that is coming out of the tumor cells in tumor lysis syndrome, that is phosphate. That is phosphate. So obviously phosphate is coming out of the tumor cells. What will happen to serum phosphate levels? Serum phosphate levels, they are increased. Okay. So the serum phosphate levels are increased. Third thing that is released from the cancer cells, okay, when you start the chemotherapy, that is uric acid. So the uric acid levels, they are increased. They are increased, and this further increases the risk of gout. Okay. Now, let me ask you a very important question here. What happens? If I ask you why serum calcium? Why serum calcium decreases in tumor lysis syndrome? Why serum calcium decreases in tumor lysis syndrome? What is the reason? What is the reason? Anyone? So just now we talked, these are the three things that are going to be increased when tumor lysis syndrome takes place. But what is the role of calcium here? The answer to this question is going to be that calcium binds to the excess of phosphate. So we just now talked that the serum phosphate levels would be more, right? So the phosphate will bind to the calcium. This is the reason why serum calcium levels, they are reduced. They are reduced. Okay, second point about it is, okay, how would you think the patient could come up? The patient could have signs and symptoms of hypocalcemia. Okay, for example, tetany, muscle weakness, paresthesias. So all of these signs and symptoms of hypocalcemia could be seen. What is the reason? Because the phosphate that was in excess, that binds to the calcium. All right. Moving on to the next point. Tumor lysis syndrome is an emergency, guys. So the management here is going to be aggressive hydration. Management is going to be aggressive hydration. Remember this. Now, the last topic for today's class, This table is very, very high yield. Okay, so when you give chemotherapeutic agent, whenever you give the anti-cancer drug to a patient, for example, methotrexate, for example, cyclophosphamide, okay, these drugs are associated with a lot of side effects. So today's homework is to read about the side effects of chemotherapeutic agents. Okay, for example, when you talk about methotrexate, what are the side effects? What are the side effects of methotrexate? Can anyone tell me? What are the side effects of methotrexate? Yes, the side effects of methotrexate include number one, bone marrow suppression. Bone marrow suppression. Second, methotrexate is hepatotoxic. Methotrexate is hepatotoxic. Third, methotrexate leads to alopecia. Yes, Monish, you give the right answer. Alopecia, hair loss. Fourth, methotrexate could lead to pulmonary fibrosis. It could lead to pulmonary fibrosis. Okay. Now, if someone is taking methotrexate and now the patient is experiencing any of the side effect of methotrexate, how would you cope up with the side effects of methotrexate? Now the question arises, first of all, what is the mechanism of action of methotrexate? What is the mechanism of action of methotrexate? So this is very, very important point from pharmacology. Okay, methotrexate is an antifolate drug. This inhibits the enzyme known as dihydrofolate reductase enzyme. So guys, this is very high yield. Please write down. It inhibits the dihydrofolate reductase. Dihydrofolate reductase enzyme. Okay. Another point. So it is an antifolate drug. So how you gonna cope up with the side effects produced by methotrexate or the bone marrow suppression or the side effects of methotrexate? So the rescue therapy is that you give leucovorin. Okay, leucovorin or folinic acid. This leucovorin is a precursor of tetrahydrofolate. Remember this point. So this is the detoxifying agent for methotrexate. Second thing, moving on to the very, very important point here. This was asked repeatedly. So they like to ask you about the cyclophosphamide. Cyclophosphamide, supposing someone has been taking cyclophosphamide, what side effects would you expect in case of cyclophosphamide? What side effects are you expecting in case of cyclophosphamide? This is very high yield, asked several times. Anyone? Remember, cyclophosphamide could lead to number one, hemorrhagic cystitis. Very, very high yield. Hemorrhagic cystitis. Second, cyclophosphamide is a drug that could lead to bladder cancer. That could lead to bladder cancer. So you see the irony. Cyclophosphamide being the anti-cancer agent itself increases the risk of bladder cancer. Okay. So hemorrhagic cystitis and bladder cancer, these are the two main important points, side effects of cyclophosphamide. So now the question arises, how you can prevent the hemorrhagic cystitis caused by cyclophosphamide? So what is the answer to this question? The answer to this question is that you can give mesna. Okay, so you can give mesna to prevent the hemorrhagic cystitis caused by the cyclophosphamide. Second question, how would mesna help? Mesna is going to provide the sulfate group, and this sulfate group binds to the toxic metabolites being produced by cyclophosphamide, and ultimately the toxicity could be reduced. Okay, so this is a very, very important point. How to prevent the hemorrhagic cystitis caused by cyclophosphamide? Your answer is administration of mesna. Right? Now talking about the cisplatin. Cisplatin is nephrotoxic. It is dangerous for the kidneys. So what type of substance you can use to detoxify the effects of cisplatin? Your answer is amifostin. So you have to learn this, very important, amifostin, which is a free radical scavenger. So amifostin is a detoxifying agent in case of cisplatin side effects. Okay. Now, this asked several times. Okay, they had asked about doxorubicin or donorubicin. So doxorubicin induced cardiomyopathy. What type of cardiomyopathy is associated with doxorubicin, guys? What is the answer? What type of cardiomyopathy is associated with the doxorubicin? Anyone? What type of cardiomyopathy is associated with doxorubicin? Exactly, Tabriz. The answer is dilated cardiomyopathy. This has been asked several times. Okay, dilated cardiomyopathy. Next question. How this dilated cardiomyopathy caused by doxorubicin be prevented? So, highlight this. This is very, very important. Dexrazoxane. Okay, the dilated cardiomyopathy caused by the doxorubicin could be prevented by the administration of dexrazoxane. Remember this point, guys, very, very important. Okay, now when you talk about the cardiomyopathy, what type of cardiomyopathies do you know about? What are the different varieties of cardiomyopathy that you know about? Anyone? What type of cardiomyopathies do you know about? We have dilated cardiomyopathy. Then we have, yes, restricted cardiomyopathy, restrictive cardiomyopathy, restrictive cardiomyopathy. Yes, any other variety of cardiomyopathy? Yes, any other variety of cardiomyopathy? Yes, hypertrophic cardiomyopathy. Okay, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Now, guys, what you have to keep in mind regarding these type of cardiomyopathies? Dilated cardiomyopathy means already maximum dilation has been taking place. The problem is with the contraction. Okay, so what type of heart failure would you expect in dilated cardiomyopathy? What type of heart failure would you expect in dilated cardiomyopathy? Your answer is systolic. Systolic heart failure, because there's a problem in the systole, the contraction. Systolic heart failure. Okay. In case of restrictive cardiomyopathy, this occurs due to infiltrative conditions, for example, sarcoidosis, hemochromatosis. Okay, all the infiltrating conditions that lead to the deposition of few substances. Okay, so what type of heart failure do you expect in restrictive cardiomyopathy? What type of heart failure do you expect in restrictive cardiomyopathy? Your answer is diastolic heart failure. Diastolic heart failure. Why? Because imagine there is a restrictive cardiomyopathy, the substances have infiltrated. So the heart will have problem in relaxing or dilating. Okay, so diastolic heart failure. When you talk about the hypertrophic cardiomyopathy, same situation. What type of heart failure would you expect here? Diastolic. Diastolic heart failure. Okay, so remember these points, they are very important. So we will end today's class, and the PDF of this class would also be uploaded on my Telegram group, that is Dr. Simran Kaur, MBBS MD. Okay, and along with that, someone from Unacademy would upload the PDFs here also. And I would be now picking up more high yield topics that would help you for all the exams in the tomorrow's class. All right, I'll see you guys tomorrow.